Alright, we're almost complete in our discussion about diuretics. We need to almost wrap things up with aldosterone receptor, aldosterone receptor competitive antagonist. Okay, so an aldosterone receptor competitive antagonist, diuretic. What is our prototype? We're talking about spironolactone. Spironolactone. And the buzzword that I really want to get out of this is you're going to have potassium sparing. If I say potassium sparing, I want you to think spironolactone. So K sparing. That is the one thing I want you to take away from this. Everything else is just extra. So let's talk about the mechanism of action really quickly, and then we'll get into a more detailed approach. So we have aldosterone production, and the aldosterone is going to be part of the renin-angiotensin aldosterone system, the little renin-angiotensin-aldosterone cycle. So if you have increased renin release, you'll have increased angiotensin. That angiotensin 1 goes to angiotensin 2, and that angiotensin 2 will stimulate the aldosterone release from the zona glomerulosa. So aldosterone is from the zona glomerulosa, and that's from your adrenal gland, so your zona glomerulosa of your adrenal gland. I do have a video on this if you want to just recap. Otherwise, that's about all you really need to know for this lecture. So we've got the aldosterone production. Now, aldosterone is going to primarily affect the principal cells in your DCT, in your distal collecting tubule, but mostly in your cortical collecting. I would start this. So your aldosterone is mainly going to affect your principal cells in your cortical collecting tubule, also your collecting duct as well, to a lesser extent. So we've got a cell here. So we're in that cortical collecting duct, and we see a cell. Here's another cell. Here's another cell. All right. So we're dealing specifically with this cell. We've got a pump that we've been talking about all morning now here. So we've got a potassium here and a sodium, and this is going to be our sodium, potassium, ATP, ACE, meaning we're going to need an ATP, but what we're going to do is we're going to drive the sodium out of the cell, in the meantime exchange it for a potassium. That will go inside the cell. We've got a channel here that we've already talked about if you've been following along with my lecture. It's got the sodium bringing it in. It's just a channel. Here's our lumen side. Here's our interstitial side for orientation. This channel is called the ENAC, the ENAC channel, right there, and we've got a channel that's going to be affected by our aldosterone receptor competitive antagonists, such as spironolactone. So I'm thinking spironolactone. This is going to be a potassium sparing. So what we're going to do is we're going to increase this channel with aldosterone. I need to make a smaller pen. I'll get rid of this really quick. Okay, let's try this again. So aldosterone is going to affect this channel and this pump. Normally in the body, we're going to increase this pump or this channel, and we're going to also increase this pump aldosterone. However, we're going to give a drug. It'll be an aldosterone receptive antagonist, meaning we're going to block the effect of aldosterone, to antagonize the effect. So if we antagonize the effect, so if we do a aldosterone receptor antagonist, I'll just abbreviate ARA, aldosterone receptor antagonist, it'll block that. So it'll actually inhibit this channel. It'll actually inhibit, ARA will inhibit this channel. And if we inhibit that channel, more sodium will get lost in the bloodstream. However, the potassium will not get lost, because here we're pumping potassium back into the cell. That potassium will leave here through a channel. Here, however, if we're not pumping it back into the cell, it can't go back into the lumen, so we're actually maintaining a lot of that potassium into the bloodstream. We're not losing that potassium in the urine, because everything that stays in the lumen goes into the urine. So if we have our sodium here, because we inhibit this channel, it can't go back into the cell, it'll stay in the lumen, it gets excreted in the urine. We're going to lose it from the body. This potassium, we're going to keep it. That's why we call it a potassium-sparing drug. The aldosterone receptor antagonists, the spironolactones, are going to be aldosterone sparing. So we're going to decrease sodium reabsorption, and we're going to increase potassium retention. Okay, so we're going to lose sodium, we're going to keep potassium. There are a couple uses. So uses for these aldosterone receptor antagonists, and the primary one is going to be diuretic. Also, typically used when the patient is in hyperaldosterone state. So in a state of hyperaldosteronism. Also, you may see it as a diuretic for heart failure. Primarily, this is what I would be concerned about. If the patient is hyperaldosterone and they have hypertension, then they'll increase their blood pressure. You'll want to give this as a diuretic to block the effect of that hyperaldosteronism. Thus, you'll lose your potassium, and water will follow. Since you have, or you'll lose your sodium. My apologies. If you increase sodium in the lumen, then water will follow. Water follows due to its osmotic gradient, and then you'll lose it in the urine. There are a couple adverse effects due to this drug. One of the possibilities is hyperkalemia, so hyperpotassium, hyperkalemia. And if a patient has high potassium levels, you don't want to use a potassium-sparing drug because you'll have increased potassium retention then. So hyperkalemia, in a patient with hyperkalemia, you could possibly get peaked T waves on EKG. That's a sign of hyperkalemia. Also, you may have absent or diminished P waves. That's a hallmark. Peaked T is a sign for hyperkalemia, while decreased P waves is also an indication for hyperkalemia. Also, an adverse effect would be like anti-steroid effects, because you could have like hormonal irregularities. You're blocking the aldosteronism. Aldosterone is going to be the steroid. You're blocking that receptor, so you're going to have anti-steroid effects, such as hormonal irregularities, for example. All right, one more diuretic to go if you're following along. Otherwise, thank you very much.